Welcome everyone to Grand Rounds today. I will turn things over to Brett Rutherford to introduce our speaker. But before doing that, I wanted to make one quick announcement. In the chat function, we post a link where people can log in so that they can get CME credits. But when you do that, it's important that your Zoom name is your full name. In other words, if your Zoom is logging you in under some other name, please go ahead and change that so we can be sure that you're getting your CME credits. So with that, I will turn it over to Dr. Rutherford to introduce our speaker.
Thank you very much. It's my great pleasure to introduce Dr. Warren Taylor, who's a close colleague and personal friend. Dr. Taylor is the James G. Blakemore Professor of Psychiatry, Director of the Division of Geriatric Psychiatry, and Associate Director of the Center for Cognitive Medicine at Vanderbilt University Medical Center. Dr. Taylor's research, broadly speaking, examines neurobiological factors influencing the phenomenology and treatment outcomes of late-life depression. This work encompasses and integrates a variety of measurement approaches from neuroimaging to ecological and neurocognitive, as well as different types of study designs like mechanistic clinical trials with pharmacologic agents and longitudinal studies examining cognitive decline and depression recurrence. In his early work, Warren and his colleagues at Duke did really fundamental work establishing the cognitive and neural changes characteristic of late onset, late life depression, and were leaders in substantiating and extending the vascular depression model. More recently, he's begun investigating additional ways that the aging brain imparts vulnerability to mood disorders. These include studies of how cognitive and affective network integrity and stress responses influence the course of late life depression, as well as projects combining neuroimaging with novel therapeutic agents to elucidate circuits relevant to neuropsychiatric health in later life. And beyond these research accomplishments, I can tell you Warren is a generous mentor and a very sought after collaborator. So it's my great pleasure to welcome you here today, Warren.
Great, thank you very much. And that was a very kind introduction. I'm going to make sure I can share my screen. This is really wonderful. It's really a pleasure to be speaking to you here today and addressing the faculty of the Columbia Department of Psychiatry. Really, nationally, there are really only, in my opinion, a small handful of academic institutions that really have a strong, robust group of researchers conducting what I consider to be really the critical clinically focused research work in geriatric mental health. And Columbia is clearly in that elite verified group. And so I really appreciate the invitation and appreciate the opportunity to talk to you about some of our work and some of our ideas. I have no commercial conflicts, and I will be discussing off-label drug use. So, as an overview, I'm going to give you a little conceptualization of how I think of late life depression and kind of answer the why should you care question, really focusing on earlier studies of cognition and brain aging. Then we're going to really spend the bulk of the talk focusing on a recently completed study looking at how structural and functional markers related to brain aging may be related to the antidepressant response and the antidepressant course of late life depression. Then finally discuss some more recent work thinking about brain aging more broadly and how aging of neurotransmitter systems may provide an opportunity to understand differences in phenotypic expression of depression, and more importantly, thinking about them as a target for intervention. So my geriatric colleagues will know the answer to these questions, but for those of you that aren't geriatricians, why should you care about depression in later life? Why is it different than depression at any other stage in the lifespan? Well, first off, like depression early in life, it's very common. The frequency, kind of the board question is that it's about 5% of the general adult or older adult population has depression, or at least DSM-defined depression. So a little bit lower than major depressive disorder in younger groups. But it really depends on where you look. And if you expand that definition beyond the DSM-4 limit or DSM-5 limitations, you can see the rates increase of clinically significant depressive symptoms. If you go into primary care populations or critical care populations, rates of depression get even higher. And certainly in nursing home or assisted living, rates of depression are even higher than that. So it can be very common in our population. They are more difficult to treat. Older adults who are depressed can have a lot of medical morbidity and also a lot of polypharmacy. We also know that while disability is an issue for all people with depression, this becomes a particular issue in later life where the disability associated with depression is compounded with other physical disability or maybe cognitive disabilities and such. And I think finally, they're harder to treat. Our antidepressants work in older adults, but tend not to work even as well as we see in younger adults. And finally, late life depression is really associated with a lot of particularly troublesome outcomes. If you have a medical illness and depression superimposed on that, the outcome of that medical illness will be worse than if you didn't have depression. This is true for cardiac disease, diabetes, a number of other illnesses, and of course, elevated overall mortality. But when we think about the really bad late life depression outcomes, the two you should always think about is first is suicide, where again, the older men tend to be the group that is the highest risk for successfully completed suicide. These are the most recent CDC data, and it's that 75 and older group that if they actually try to go forward with a suicide attempt, they're the ones most likely to succeed. This is less of an issue for women. Certainly the 45 to 64-year-old range, the oldest of those may qualify, depending on your definition, as being in the geriatric age window. But by and large, older age is not as big a risk factor for women. And of course, women don't have rates of completion to the extent we see with men. The other thing, and this is where I've spent a lot of time, there's been a lot of research focused on this recently, is dementia risk. A number of longitudinal studies in the US, in Europe, in Asia, everywhere, have fairly consistently found that if you're older and depressed, your risk of dementia is pretty significantly increased with an odds ratio of just about 2. And so this is not a benign thing in our older adults. Now, the dementia risk really shouldn't be a surprise. We've known for, at this point, literally decades, that cognitive performance is impaired, or at least we see people performing below their capability when they're depressed. This goes back to work from Merrill Butter's group in Pittsburgh, showing that in a cohort of older adults with depression, you see people that meet a criterion for impairment across a wide range of cognitive domains. And I think what's really interesting about this work, and this will be a theme you'll hear throughout the talk, is that the effect of depression on many of these domains seems to be mediated by processing speed. And so in this paper, and I think this is supported by subsequent work, processing speed is often viewed as kind of a key cognitive hallmark of late life depression. Now, other groups, like the group from Cornell, is really focused on the role of executive dysfunction, particularly as it may be predictive of antidepressant response. So it's not that these other domains aren't important, but processing speed may hold a really key role in late life depression. Interestingly enough, it may also play a key role even in depression across a lifespan. This is a study we published a couple years ago in my brief foray into younger adult depression, where we look at cognitive performance in people between the age of 20 and 50. These are people that had a particularly early onset of depression. And although we found signals for episodic memory and executive function, really the cognitive domain that did stand out that was different between depressed and never depressed people was a deficit in processing speed. Now, when we think about these deficits, these are all cross-sectional data. It's a snapshot in time of how the cognitive performance looks. And we know it changes. This is a study led by Deanna Barch that was looking at data in a clinical trial done between WashU and Duke, and looking at how cognitive performance may change with acute antidepressant treatment. I think this was a placebo-controlled trial using sertraline. And what we see is in a number of domains, you see sometimes a dramatic improvement in cognitive performance, notably in episodic memory and executive function. But other domains, even with successful treatment, may not improve quite so substantially. So again, here's our friend processing speed. I think what's also important to keep in mind when you look at these data is just because you've seen improvement, it doesn't mean they're getting back to age-adjusted norms. And I think data from Pittsburgh as well as other groups are very, very clear that even people that exhibit improvement in cognitive performance with successful antidepressant treatment, many of them continue to perform more poorly than you'd expect. And so what do we know about how cognitive performance does change over the course of time? And how does this inform us about this risk of dementia? These are data from our longitudinal study of depression at Duke University. And what you see here in a very, very simplistic way, we followed people longitudinally for about 4 to 5 years, both depressed and never depressed elders, looked at a whole range of a neuropsychological battery that we were then able to consolidate in some cognitive domains. And we see that if you're depressed, even with ongoing naturalistic, doing the best job we can type of antidepressant treatment, the individuals who are depressed do exhibit a greater rate of change over time than the never depressed elders. Now, this, to be fair, is not dramatic. We're not seeing a huge rash of people that are with depression convert to dementia in a year or two. But it's a more subtle change, but is definitely a more rapid change that may account for this greater risk of dementia, at least for some people. Now, as part of this project, we also want to look at clinically relevant phenotypes to say, are there differences in the rate of cognitive decline across different phenotypes? And so we looked at acute remission. And I have to tell you, these data really broke my heart. And so we kind of broke the group down to whether at 3 months, were they remitted or not. And so this, again, was a naturalistic kind of algorithm-driven treatment. So we did the best we could to get people better. And so we thought this was a useful approach to look at people who had responded very, very rapidly and people that hadn't. And I'd always had this fantasy that for my patients that had a robust antidepressant response, that they would have a better cognitive course. I wouldn't have to worry about them developing dementia. And these data very clearly show that's not the case. Now, we do have in a couple domains that the non-remitted group, the people that had a poorer course, seem to look more like the never depressed controls. I'm not sure I buy this. I think there could be a survivor's effect for the people that really had a really difficult course of depression, may have dropped out early. Some informal communications with Meryl Butters at Pittsburgh suggests that she has not been able to replicate this finding. But I think overall this shows that acute remission is not a good sign that you will have a better cognitive course. It's not predictive of resilience to dementia, I think is the best way to put it. So when we start thinking about this cognitive decline, obviously we start thinking about brain aging. And this takes us back to 20 years. And I've reflected recently, as now I've been doing this research as faculty for 20 years, that back in the day, before we had Free Surfer, before we had Con, before we had really appreciated the value of resting state fMRI, we measured things we could measure. And the first things we measured were clear markers of structural brain pathology. First off, we looked at these white matter hyperintensities. And so those of you who don't do this type of work, these hyperintensities are these blobs in the parenchyma of the brain that should not be there. In late life depression, they're more common in depressed elders and more severe. They can have a multifactorial etiology, but what we know in late life depression are primarily vascular in origin and also associated with advanced age and vascular risk factors like diabetes, hypertension, and such. And we also know that as this disease progresses over time, it's also associated with cognitive decline. The hippocampus is similar to something we looked at, again, stealing ideas from Alzheimer's literature, something that was fairly easy to measure. We used to have the armies of image analysts hand tracing these hippocampi, again, before Free Surfer. But what we clearly saw associated with late life depression, and much like depression even in younger adults, a fair amount of evidence suggests that depression is associated with smaller hippocampal volumes. But again, these are cross-sectional studies looking at change in time and doesn't really address how this pathology may change over time and how that change could be related with depression outcomes. So my earliest work in this area was really looking at a 2-year change in hyperintensity volume. And what we found in the individuals who remit, who are in blue, and people that really never remitted despite our best efforts over the 2-year period, the people that had a more chronic, difficult to treat course of depression had a much more rapid increase in hyperintensity severity over the course of this 2-year period. Now, what was interesting to me is just looking at any time point, it looks like the remitted group actually has a greater hyperintensity volume than does the non-remitted group. And statistically, this was not correct, although visually it certainly looks like it. I think the point is that this persistent depression is associated with a more rapid accelerated brain aging, looking at hyperintensities as that marker. Several years later, we found a very similar pattern for hippocampal volumes. So this is looking at hippocampal volume across both hemispheres. And what we find is when we look at people who are remitted, maybe remitted and later relapsed, it's this group of people that never remitted despite our best efforts to treat them and get them better in a longitudinal fashion. They have the greater rate of hippocampal atrophy over 2 years. Now, this shows you the limitations of even good longitudinal data in determining causality. I can't tell you, is this a more difficult, more chronic, more malignant depression that is accelerating brain aging, or is it people who are experiencing accelerated brain aging? Maybe that's having a negative effect on our ability to treat the depression. I can't really answer the chicken and egg, but it does show that these two things are related and really, really dangerous. Now, this goes into, I think, segues into, this is probably one of my favorite papers over the last decade, where I'm obviously not the only person interested in how brain aging and brain pathology may relate to depression and cognition. So this came out of the ADRCs from Russian University of Pennsylvania. They took 1,800 people they followed on average for 8 years. Almost 600 of them got to autopsy. And they were assessed annually looking at not only cognitive performance, but also depressive symptomatology. And the study came out with a number of kind of critical findings, but the two that really, really stand out. One is to show that as you look at cognitive decline over time, if you are depressed on top of that, the level of cognitive impairment and the degree of cognitive decline you see is greater than you expect by the underlying neuropathology by itself. So you expect a certain level of decline based on the neuropathological analysis. At autopsy, depression is additive or cumulative to that. The second thing they found is that depression was not linked to specific neuropathology. It's not all vascular, it's not all amyloid, it's not all Lewy body. It cut across those pathologies. And so the conclusion is that depression really has this associated cognitive decline that is independent but additive or cumulative with the underlying neuropathology. Great. Well, what is the mechanism? What is depression doing to cause this? So with that kind of introduction, I now want to shift gears and talk about our study, looking at how brain aging may be related to acute antidepressant outcomes. And a lot of this was initially built off the vascular depression hypothesis. It's had a number of definitions over the years, both from the Cornell group as well as our group when I was at Duke. And I think it's really still summarized best by George Alexopoulos' quote about the cerebrovascular disease may predispose, precipitate, or perpetuate some geriatric depressive syndromes. I always think this is very interesting because this is one of our very earliest approaches in trying to ascribe causality for psychiatric illness. Now, this hypothesis led to a significant amount of research over the early 2000s and really looking to see, does this vascular disease, do white matter hyperintensities, are they predictive of a poorer course of antidepressant treatment? Do they identify people less likely to respond to treatment? And the answer is, well, it's really kind of mixed, and there's a lot of heterogeneity across studies. My read of the literature across all this writ large is that hypertensives probably do contribute to a little bit of treatment resistance, but it's modest. It's not the biggest factor that may predict it. And I think that functional measures of how the brain is working, particularly neuropsychological measures, may be actually more robust predictors of acute antidepressant response. Now, all this being said, we do know that hyperintensities affect brain function, or at least are associated with alterations in brain function. A lot of this came from work done by the University of Pittsburgh with Howard Eisenstein's group. And we see that greater hyperintensity severity is associated with executive network functions, looking at digit symbol substitution, associated with how the brain responds to effective stimuli. And even for the default mode network, it's looking at alterations in connectivity between the anterior and posterior hubs. So yeah, these have functional consequences. We also, Vetcheline's group and my group also started investigating to say, the brain is really, really complicated, and maybe this global measure of hypertensive severity is not really the most focal way of looking at how these measures may contribute to depression. And so a number of groups really looked to see, could we localize fiber tract damage where these hyperintensities may have a more specific relationship with late life depression? And we found a series of fiber tracts that looked like they were associated where individuals who were depressed exhibit maybe a specific relationship with greater hyperintensity damage in these areas. Looking at the superior longitudinal fasciculus, which is a really broad association tract, but then also looking at more focal tracts, including the cingulum bundle that runs right over the cingulate gyrus, connects anterior and posterior hub areas of the default mode network, and also has a posterior limb that wraps around to connect to the hippocampus. And we also got interested in the uncinate fasciculus that connects inferior frontal areas and even some subgenual cingulate areas to temporal and medial temporal structures. Now, this got even more interesting to me as we did some secondary analyses, really, to be fair, exploratory analyses, where we were looking at how these may be related to treatment response and treatment outcomes, and quickly honed in on this posterior limb of the cingulum bundle, where we found a relationship with treatment response. Again, pulling in longitudinal naturalistic data from Duke. Over the course of 3 and 6 months, individuals characterized by a higher degree of hyperintensity damage in these tracts tended to have a less robust response to treatment than individuals that have minimal or low hyperintensity damage to this tract. So pretty interesting. This led to the study we're going to talk about, what we call the CAARe study, still one of my favorite acronyms we've come up with. And it was really designed to try to have a multimodal imaging approach to link structural tract-based damage with our increasing, at the time, improving conceptualization of these intrinsic functional networks and how structural damage may be linked to functional network alterations, and really have that superimposed on a very traditional clinical trial design, where after our initial screening and neuropsych and imaging assessments, people randomized in a 2-to-1 ratio either to receive escitalopram or placebo. This is what we're going to focus on today. We do had an open label phase 2 arm that we're not going to talk about, has a much smaller N because if you remitted, you were graduated from the study, but there's more to come. We're going to talk primarily today about this phase 1, but also talk about diagnostic differences. We're going to talk about cognitive performance differences and treatment outcomes, looking at different measures of structural connectivity, other measures of brain structure, talk about some data with amyloid and floor beta peer that was a sub-study, and finally hone in on functional connectivity. And I do want to give you the caveat that analyses are ongoing. And so these are, if you read a paper from me a year from now or 2 years from now and say the story looked different, I apologize, but this is very much a work in progress. I'm not presenting these data anywhere else. To kind of orient you, first off, we actually got a drug effect. And this honestly may be the most surprising finding we've had from the data so far. Typically, to show a treatment effect, a change in moderates, you require a sample size, maybe 100, 200, 300 people, certainly not within an N closer to 100. So I was gratified to see this, even though this was not an aim of the study. So to start us off, how we wanted to look at these tract-specific effects and how hyperintensities may adversely affect these fiber tracts. This is not a small issue to address. We can't really use the traditional methods of tractography because these hyperintensities, which are really the thing we're interested in looking at, they really disrupt tractography pretty substantially. And so if you try to use classical tractography and you have someone that has a big hyperintensity or other lesion smack down in the middle of the tract, the tractography fails. So you can't measure the things you're most interested in. On the other hand, we started talking about using more traditional white matter atlases, and even a number of years ago, there were a number of these around, but these were all developed in college-age students, people in their early 20s, not necessarily applicable to an older adult population. And so working with colleagues in biomedical engineering and computer science, we identified some individuals who are neuropsychiatrically healthy, in the same age range as our clinical sample, and people that had minimal vascular disease, but at the same time had the usual age-associated atrophy, both in the gray matter and presumably in the white matter. And so we had this nice age-specific atlas that then enabled us in a probabilistic way to superimpose the atlas on individuals' white matter lesion masks, so we come with an estimate of what proportion of these tracts may be occupied or disrupted by hyperintense lesions. So first, getting to some of the data, these data are looking at diagnostic differences, expands a little past the actual study itself into a second study that had comparable entry criteria. And what we see is actually we don't see a group difference in hyperintensity volume as a whole, so throughout the cortex. This isn't surprising, although overall depressed elders do exhibit a greater severity of hyperintensities. There are definitely negative studies. The difference between the groups is, in my mind, very comparable to what other studies have been. And it just, in the model we had, it didn't achieve that magical threshold p-value, which is fine. And actually, I think it simplifies our understanding of some of the data I'm going to present because there's not a group difference in this total cerebral volume. So what about our a priori areas that we're interested in? Well, of these areas, the only difference we found was in the right cingulum. Okay, so depressed people exhibit a greater hyperintensity burden in this area, clearly supporting past work in this fiber tract, but not the others. A little disappointing, but we did find some relation to some unexpected fiber tracts, specifically some that involved the hippocampus. So the first I want to talk about is the fornix. So this is a C-shaped bundle of nerve fibers that really serves to be the major kind of outflow fiber tract for the hippocampus. So mainly efferent fibers. It does have some afferent fibers, but it's a particularly interesting fiber tract as there's some data shows that damage or transection of this fiber tract may be associated with memory loss and memory impairment. So really, really interesting. And we found both on the right and the left that the depressed individuals exhibit a greater hyperintensity severity in this fiber tract. Now, we also find something in the anterior commissure. So this, if you look at a coronal cross-section of the brain, this is right below the columns of the fornix. And this is really a fiber tract that connects the two temporal lobes across the midline. So the corpus callosum still is the primary fiber tract connecting the left and right hemispheres, but this is not an insubstantial fiber tract and does play a key role in the temporal lobe and also the hippocampus. And here we find a very similar difference between our two groups. Now, I'm not going to present cognitive data to you today, and the reason why is the first question to say as well, if this is really the hippocampal function, is damage to these tracts associated with episodic memory function? The short answer is yes, but the long answer is it's complicated. So yes, in our initial analyses we've been running, we are finding a signal where greater damage to all of these tracts are associated with memory impairment. However, it's not specific. We're also detecting a signal for some of our executive function measures, and we're also finding a signal where damage to other tracts may be related to episodic memory performance deficits. So interesting, supportive, but the final story isn't in, hence I'm not going to go into more detail. Now, the other question is, could we replicate our prior finding? Are these things related to treatment outcomes? And the answer is, at least in our preliminary analyses, is no. So a little bit disappointing. But at least we're not finding any robust support that any tract-specific damage is predictive of a poor response to antidepressants. So with that being said, I'm going to shift now to a different measure of brain structure, and really, in my mind, more a measure of accelerated brain aging, which is using MRI data to estimate a person's age, so brain age estimation. This was a technique developed at Vanderbilt. There are other groups across the US and Europe that are developing comparable techniques. This is really a computational deep learning approach to use only the data from a T1 scan to estimate someone's age. So what our colleagues in engineering did is they took really a huge collection of over 5,000 scans across, I think, 9 different data sets, really across the age range from 4 to 94. And they used both volumetric measures as well as other image intensity measures to help train their deep learning algorithm to try to identify what the actual age is of the participant. This shows you that they're able to do this, and that really this combination across the two modalities gets a better estimate than either one by itself. You know, one of my questions was early on, is this all just measuring the larger ventricle size or hippocampal atrophy? And the answer is no, it's doing a lot more than that and looking at a lot of numerous features. And this just goes to show you here, looking at this bottom row of people that are older, that you see sometimes it got it right. So you have some people where the true age and the predicted age were both at 78, so spot on. You have other people that may be where you're underestimating pretty substantially. So the actual true age of this person was 88, was read as having the brain of a 38-year-old. I'm not sure I buy that. But then here, this is what I want my brain to look like. A 50-year-old was read as a brain of a 20-year-old. As someone in his early 50s, I would argue that 50-year-olds should not be classified as an older adult, number one. But if I am, I do want the brain of a 20-year-old. This difference, although we have this mean age gap between the two in the cohort as a whole of about plus or minus 4 years, it provides us an opportunity to look at the gap. So what is the difference between the calculated age and the chronologic age? So if someone's 60, but is being read as their brain looks like that of an 80-year-old, does that positive 20, saying your brain is older than we expect, is that clinically meaningful? And this is actually the question our colleagues came to us with. He said, does this tell us anything more than what we can ascertain just by asking someone how old they are? You know, does this actually tell us something useful? And I think the answer is maybe. So I think this is conceptualized again. There's a lot of work in brain aging, not only in depression, but across other psychiatric illnesses such as schizophrenia and others. Probably the most famous accelerated aging marker there is telomeres, where as we age, the telomeres on our chromosomes get shorter and shorter, and some people, they shorten more rapidly. The problem is many of those aren't brain-based, so we really appreciated having one that was going towards our organ of interest. And we found very, very quickly, we published this last year, that older adults do have on average an older appearing brain than we would expect. I was gratified to see that on average, our controls really float right around 0. And so, yeah, there is a range. Some people have older appearing brains, some people have younger appearing brains. On average, it was right around 0. So they were called what you would expect based on who they were, and our group is a little older. Now, these also have other clinical implications, which I found really interesting. Again, these are all cross-sectional data, so take them as they will. But we found that an older appearing brain is associated with greater disability. This is in our entire cohort, both depressed and non-depressed people. So if your brain is older, you have more difficulties. I don't know, again, is this a chicken and egg phenomenon? Does a disability lead to accelerated aging? Or does an older appearing brain contribute to the greater disability, or is it a little bit of both? And we're also finding associations with cognitive performance. Again, these are very modest effects, where if you have an older appearing brain, you tend to overall do poorer on tests of episodic memory. And in the depressed cohort alone, so getting rid of the non-depressed elders, we see a similar signal for processing speed. Whereas your brain appears older, people tend to perform more poorly on tests of processing speed. So 2 things to comment about this. This is a very general measure of accelerated aging. So we're looking at a single number, but that single number is having, admittedly, a modest effect on cognitive performance. The second comment I want to make is, again, we're seeing how processing speed may have particular importance in our depressed population, which I find very interesting. Now, the question is, does this affect antidepressant response? And the answer is no. And so using, again, a mixed models approach, it's always difficult to try to graph 3 continuous measures in 2-dimensional space. But when we look at our measure of brain aging, where again, as you go to the right, those are the people that have older brains than you expect by their age alone. You see that really there's no difference over time across these 5 lines in terms of depression severity. So while depression severity does improve over the course of time, this is not related to brain aging, at least by this measure. So may not have any predictive value. This is a negative finding, but I think it's a very encouraging finding because again, if you look at an MRI of some of our patients and you say, gosh, this person's brain looks really, really bad. And this does not look like the brain of a 60-year-old or a 65-year-old or a 70-year-old. Well, that's okay. I mean, that may be bad for other reasons, but it doesn't mean that they won't respond to the treatment you offer them. So they can still respond to antidepressant medication, which is encouraging. Now, this story may not be true for amyloid deposition. And so we've known a lot about amyloid deposition for a number of years. There's a lot of work looking at CSF measures. primarily focusing on CSF A beta 42 levels, where a lower A beta 42 level in the CSF is associated with MCI or Alzheimer's disease. And in meta-analyses, we find a marginal level of significance that people with late life depression tend to exhibit lower levels, similar, like I said, to MCI. More recent work, this is a study that came out of Taiwan, looking at floor-beta pair with PET imaging, finding that individuals who have depression compared to non-depressed elders exhibit greater A-beta binding in the parietal lobe and precuneus. Now, this study was a little problematic because they had a wider range of cognitive performance. But just recently, Gwen Smith's group from Hopkins came up with a study looking at really cognitively intact individuals with late life depression, comparing them to age-matched controls, and finding that, unfortunately, yes, even in this cognitively intact group of depressed elders, they in the superior inferior parietal lobules, they do exhibit greater binding with PIB. So definitely more A-beta binding. And to some extent, the degree of binding in these areas was correlated with a greater depression, severity of depressive symptomatology. So it does appear that for many of our depressed elders, A-beta is a real issue. In parallel, we published this pilot study just last year. And this was a is an exploratory analysis, kind of an additional study, an add-on study to our main care study, where we also had them scan with floor-beta pair. So we enrolled 27 people in this sub-study. These were overall very cognitively intact individuals. Our 2-to-1 allocation worked. By and large, people got better. Using the kind of threshold of declaring someone as amyloid positive or negative using the standard SUVR threshold, only 5 of our 27 people met that criterion. But even with this kind of crude cutoff, you can see very clearly that they have a higher ratio of non-remitters than the A-beta negative people, and by and large have less improvement in depression severity than the A-beta negative people. When we graph this out, again, these are very small sample sizes, very small n's, so take them as you will. It's very, very clear that when you break them down by amyloid status, the A-beta positive people just have less improvement. And even when we look at binding as a continuous measure, we still see this very strong relationship. Now, it's not all amyloid. And I want to draw your attention to these people down here in this bottom left quadrant of the graph. These are people that are clearly amyloid negative. And these are also people that really their depression severity did not budge with treatment. And so I think amyloid is a significant contributor, but it's not driving everything. Just to answer the question I know that I forgot to mention is that in these analyses, we did adjust for treatment, and we did not look for any treatment by amyloid interactions just because of power issues, and that was a step too far. But we really, treatment, I think, had a marginal p-value here. So it was not quite as robust as what we saw in the overall sample, but we did get a signal where the drug was doing something. So, and I think this is just to hammer home the point that even though we found that amyloid deposition seems to be a poor prognostic factor for an antidepressant response, this should not be surprising. There's been a series of work, mostly, although not exclusively out of Hopkins, looking at how depression as it occurs in MCI or Alzheimer's disease may or may not respond to antidepressants. This is their DIAD study from Paul Rosenberg and Kostas Lyketsos and others, and really showing that it's really difficult to treat depression in Alzheimer's disease, which of course is characterized by significant tau and amyloid pathology. So now with this, let me shift away from the structural and even molecular measures and talk a little bit more about network connectivity. So here we're functioning clearly on the seed areas, standard intrinsic functional networks that have now permeated psychiatry. And in our initial analyses, we used seized-voxel analyses, and we just want to look, are there group differences? And we found across these 3 networks, there was one, mainly in the default mode network between posterior and anterior hub areas. But this connectivity was not really associated with anything clinical. So it was kind of boring. Yes, it implicates the default mode network, but nothing dramatic. We then decided to look at how it may affect the clinical presentation of depression and really focused here on cognitive control network function, finding that between the left DLPFC And other key areas in the cognitive control network, both the dorsal anterior cingulate and the supplementary motor cortex, that we do see with increasing connectivity between these areas, we see increasing depression severity. And what's even more interesting for the supplementary motor cortex finding, these are correlated with other more granular measures of depression severity, both anhedonia using the SHAPS and fatigue. And so here, greater connectivity associated with greater depression severity. But the point I want to make is we're not observing group differences in these measures. And so even though we have a wider range in the non-depressed people because we have a smaller N, they're very, very comparable between groups. And so this just goes to make the point that you can have connectivity measures that look to be within the normal range what you expect for a given population or a given age, but it has a different implication for people that are in the midst of a depressive episode. So it may mean there's other elements of these networks that we're not detecting in these analyses. We found a very similar relationship with cognitive measures in these analyses, where to kind of simplify a complicated story, looking at measures of working memory, episodic memory, and some executive measures, by and large with increasing connectivity in the controls who are in red, those are associated with improving cognitive performance or maybe a neutral, so really no relationship. However, when we look at all the people in green, we see that curve gets shifted down. So their performance actually gets a little bit worse with increasing connectivity. You know, it's difficult to make these functional comparisons, but I will say this does lead to the comment I want to make before, where the relationship between regional connectivity may differ depending on the state they're in. Now, what does this mean for treatment response? Here we took a little bit of a different approach so far, where we, rather than do a seed to voxel analysis, we're doing the seed to seed analyses. We had a number of a priori hypotheses, largely built off the Embark study, which did a similar study in younger adults, a much larger study in multi-site. But we used our a priori hypotheses augmented by some of the data from Embark to try to figure out what elements of these networks and what's very specific kind of C2C connectivity should we look at. And then we were able to integrate these measures into models predicting depression change over time, and really trying to look at some more interesting statistical interactions about how connectivity may predict change in MADRS over time, or maybe related treatment effects on MADRS, or three-way interactions. And so I'll walk you through some of these. The first findings were really focusing on the relationship between the posterior cingulate cortex, so the default mode network, and the hippocampus. And what we see here on both of these, for the right, we see this nice interaction where with increasing connectivity, you see people have this interaction where people with higher levels of connectivity exhibit an overall lower level of depression severity across the study. Now, it's not a time effect because time was not relevant to this interaction. But we do see that overall, they just have persistently lower MADRS over the course of the study if you receive drug, not if you receive placebo. In contrast, so left hippocampus, we don't find the treatment interaction component, but we do see a time effect. So that over time, if you have an increasing connectivity between these areas, you see a greater change in depression severity over time, regardless of what treatment you had. So either way, you want to have increased connectivity between your PCs and your hippocampi. Now, we found a similar relationship in the anterior hub of the default mode network, specifically between the right medial prefrontal cortex and the rostral anterior cingulate cortex, both on the right and the left. On the right, we find something very similar to what we just showed, where you have this interaction between connectivity and treatment, where you have a more positive connectivity. You see the segregation where these are people that tend to overall over the course of the study have lower depression severity if they receive drug, but not placebo. And we find this really interesting three-way interaction. So if you get drug and you have a positive correlation between these groups, you see a greater change over time, where if you have placebo and have higher levels of correlation between these areas, these people just don't budge over time. So very, very interesting. And finally, the last relationship I want to kind of comment on is relationship again with the left hippocampus, but here with the subgenual anterior cingulate cortex, but in the opposite direction, where people that have lower connectivity, reduced connectivity between these areas, those are the people that tend to have lower depression severity overall. So these are complicated data to kind of digest. And I think that the take-home message I want to give is, if we think about kind of categorizing this as a good drug response, meaning that overall, over the course of treatment, they tend to have lower drug severity when they receive drug. This is categorized by increased connectivity between default mode network areas, medial prefrontal and rostral anterior cingulate cortex, but also the PCC and the hippocampus, with lower connectivity, reduced connectivity between the subgenual anterior cingulate cortex and the hippocampus. Now, I think that in the big picture, there's a lot of limitations with these data. We're early on. It does support involvement in the default mode network. Broadly, there's a concordance with what we see in younger adult populations, and may have some utility to help understand how people may or may not respond to placebo. But we've made multiple comparisons. In full disclosure, if we adjusted for multiple comparisons, none of these would be significant. These are a priori analyses only, so if we didn't measure it, we couldn't detect it, and we have a lot of work to do. So stay tuned would be my message here. And I think my take-home message for you is that when we look at structure versus function, clearly function plays a bigger role. Our structural measures, whether it's a brain aging or hyperintensities, just is not as proximally related to the antidepressant response as our measures of brain function. This may not be surprising. I think the challenge is understand how these things are related, and really how can we clinically translate our connectivity findings into ways that are clinically actionable. All this being said, I'm going to take a pause, and we want to kind of shift our talking now to focusing on thinking about how we can use other approaches to think about brain aging, and particularly changes in neurotransmitter systems. So all the changes we see aren't related to brain atrophy or changes in connectivity or changes in white matter integrity. But of course, we know that neurotransmitter systems involved in cognition, affect regulation, stress response, all these things change as we get older. And so we have a couple ongoing studies looking at these things. The one I'll be talking about today is our Depressed Mind study, looking at transdermal nicotine. I also want to kind of comment that we have another study going on with our very own Brett Rutherford here, looking at how dopaminergic system processes may contribute not only to phenotypic expression of depression in later life, but how modifiable the system is with L-DOPA, and how this may modify some of these dopamine-related behaviors. So we can talk about that more in the question-answer session if you like. So why would we look at the nicotinic acetylcholine system? This is a really, the nicotinic, actually the acetylcholine system writ large is a very complicated system. But we also know this has a negative, this has changes with aging. When we look at nicotinic receptor binding, we clearly see in the frontal cortex as well as medial temporal structures, we see decreased binding with accelerated aging. Similar things are seen in basal ganglia structures. And we see these effects not only in normal aging, but also pathologic aging, where in studies of Alzheimer's disease in animal and human models, we see that there's co-localization of where we see nicotinic acetylcholine receptors are expressed with amyloid beta binding. And so they get very easily co-localized. So not only do we see changes with normal aging, but pathologic aging plays a role as well. This shouldn't be a terrible surprise. Our main treatment we have for treating cognitive dysfunction in Alzheimer's disease targets this very system. So these are the acetylcholinesterase inhibitors. Now they don't work very well, but they're at least targeting this system. So it's been a focus of research for a very long time. But the question to ask yourself is why would anyone in their right mind want to give nicotine to older depressed adults? We have literally millions of dollars have been spent on getting people to stop smoking. And I never would have thought of this 10 years ago, but when I came to Vanderbilt in 2012, I started working with my now partner in crime, Paul Newhouse. And at that point, he had just published a study looking at transdermal nicotine for mild cognitive impairment. And he, in an initial pilot study, I think of 60 people in a multi-site way, found that transdermal nicotine, given over 6 months to people with MCI, has improvements in sustained attention and improvements in episodic memory. And I said, this is great. I would love to be able to improve attentional performance, memory performance, maybe even executive performance in my older depressed adults, because like I said, even when we treat them with antidepressants, we see residual deficits. Now this, to be fair, is not a new idea. And this goes back into the 70s with David Janowski, who, interestingly enough, was a prior faculty at the Vanderbilt Department of Psychiatry. But he had a different hypothesis, where I was interested in nicotinic receptor agonists for this question. He had a proposal to say that depression may be related to adrenergic hyperactivity or increased cholinergic tone. So he always thought that maybe cholinergic receptor antagonists would be the way to go to really look at the antidepressant response. And this actually led, over the next couple of decades, a series of studies, first looking at mecamylamine, that is a nicotinic receptor antagonist, showing preliminary efficacy in animal models and early human models. This led to studies of dexmethylmylamine, which is a nicotinic channel modulator that has kind of, again, antagonist properties, showing in preclinical studies and early human studies showing, hey, this may have benefit to depression and depressive-like behavior when used as an adjunct to SSRIs. But then we did the 4 acute phase 3 trials. All of them were negative. It did not separate from placebo, and so I kind of killed that line of research. However, we do have these ongoing parallel studies looking at nicotine or other nicotinic receptor agonists. This is a study by Joe McLernan at Duke showing that even in very low doses with nicotine gum in younger adults, you may have a modest antidepressant effect. And that just for the 28 days, to be very clear, this is after they were withdrawn from the drug and you see a return to prior depressive symptomatology. Now, there is a much bigger literature in this. There is a fair amount of animal literature supporting nicotinic agonists may have benefits to depressive behaviors, a whole literature in smoking. If you ever talk to people that are current or past smokers, they'll say that smoking doesn't help their mood. It helps how they manage stress. And there's a whole literature in many people that do successfully stop smoking. You may see an emergence of depressive symptomatology afterwards. It doesn't appear that this is a withdrawal effect, but it does seem, at least as my real literature, that may be a true unmasking of previously unrecognized depression. Then we also know that even in other impaired groups that may improve attention, memory, and really enhance cognitive control. And so this is a study that really got me excited about this project. This was what they call an fMRI task-independent meta-analysis. So they took all the studies that have been done looking at what nicotine does for people in the scanner where they're engaging in externally directed, attentionally heavy tasks. And what they found is across all these tasks and across all these populations, when they compared people on and off nicotine, if you're on nicotine, you see increased activity in executive networks, cognitive control network function, and decreased activity in areas of the default mode network. So areas that shouldn't be active anyway when you're engaged in externally directed tasks. And I thought this was really interesting because this network model seemed to fit beautifully with the network deficits we often see in depression, which is characterized by increased activity in the DMN when we don't want it to be active, but really a suppression of executive network function and maybe playing a role in the salience network, although I think that's becoming a little less of a target in depression at the current point. So we did an initial pilot study, open label, 12-week rigid dose escalation, 15 people. We had a combination of, none of them were current smokers, but about half were past smokers, some were negative non-smokers. We were agnostic about the right design. Is this really for people that it's an augmentation approach, or could it work as monotherapy? But I can tell you, we found a fairly robust response in depression severity over time. Again, open label trial, take it as you will, but very, very encouraging. Overall, well tolerated with a couple important caveats, where as we titrated the dose over time, we did see a dose-limiting effect in about half the sample. Again, if you've spoken to anyone who's ever been a smoker or even a kind of occasional smoker, you could guess at the side effects where you see lightheadedness, dizziness, nausea, even vomiting. So at those people, we stopped the dose, we dropped it back to 10.5 milligram dose, and they seemed to do just fine and still had, in many cases, a good clinical response. When they stopped drug, there was no withdrawal, there were no cravings, vital signs were stable except for weight, where we saw a slight decline over time. which I thought was pretty cool because most of our antidepressants, of course, cause weight gain. Now, these data are interesting and useful preliminary data, but as you know, within IMH's current experimental therapeutics initiative, are not sufficient to really talk about mechanism and what the drug may be doing that may mediate the effect to produce this antidepressant response. And so this is where my colleague and collaborator, Faith Gunning, came in. And she said, you know, as we're designing the study and thinking about pre and post MRI, she said, you should consider doing the emotional Stroop task. So this was developed, the version developed by Amit Etkin at Stanford. And this is where in Scanner, people are shown faces either with a fearful expression or a happy expression. And of course, they're instructed to ignore the word and say what the face looks like. And so you have the congruent and incongruent conditions. And I really like this because, of course, this task involves conflict monitoring and ignoring stimuli, and also probes the ability of how emotional stimuli may draw attention from the primary goal of the task, which are deficits we see in late life depression. I mean, they have difficulty with this. So it seemed like this was a perfect task, try to get at the hypothesis that is nicotine really enhancing these executive control network functions that we know are impaired in late life depression. And the signal we had was really encouraging. And this is worth just a pause to kind of walk you through this very quickly, because it's always a challenge to interpret task data. So when we think about the contrast between these conditions, we're really comparing how the brain is responding between the congruent and incongruent conditions, right? The incongruent conditions, when the face and the word don't match up, is really, that's the harder one for people to navigate. So we see that their accuracy is less, it takes them longer to respond, and we tend to see an increased level of brain activation with this. So when we compare these two conditions, they're working harder for the incongruent condition, but also see a higher level of brain activation. So when we look at this pre and post nicotine, what we found is the people that had the more robust response to the treatment and had the greater depression, improvement in depression severity, we saw a closing of the gap between the congruent and incongruent conditions. So the brain activation to the incongruent condition shrank, it went down. It was easier for them to do this. We saw not only in the measure of brain activation, but also their accuracy improved and the reaction time was faster. So we had the imaging and behavioral markers to suggest this, and this helped us really interpret this as saying, hey, this may be a marker of enhanced executive control network function, and we thought this may be one mechanism of how nicotine was contributing. My final two comments is to propose an alternate hypothesis for you, and also to try to help you reconcile this difference in the basic literature of the agonists and antagonists. So if you really get interested in the nicotinic acetylcholine system and how that may relate to depression and the phenomenology of depression, I can only, with my strongest recommendation, recommend you to anything written by Marina Picciotto and Jan Manura from Yale. They are the experts in this. And they have been struggling from this from a basic science point as well. And I think their most recent model, I think, is really helpful, where they have proposed that with increasing cholinergic tone, at lower levels, and this is across both nicotinic and muscarinic receptors, we see normal function of memory storage. And as we increase the cholinergic tone, that helps us focus our attention, particularly to salient stimuli, but also may kind of increase our stress reactivity. And so as we increase, this favors hypervigilance. And as we go even further, this may particularly favor a negative salient. So we may have a maladaptive attention negative stimuli. And it may also contribute to a maladaptive stress response. And so this sounds very much like what we do see in many of our patients with depression. And so this fits with their hypothesis that nicotinic receptor antagonists could kind of make this go backwards, so lower the cholinergic tone and potentially have therapeutic benefit. Now, what does this mean for the agonist? Well, with the agonist, the idea is that in some ways nicotine could have, even though it's an agonist, could have antagonist properties. So the hypothesis really is founded on two observations. One is that nicotine is not as robust an agonist as is endogenous acetylcholine. So now you have endogenous acetylcholine that is kind of competing with nicotine that doesn't quite activate the receptors as robustly as endogenous acetylcholine does. So overall, you're lowering that cholinergic tone, even though you're using an agonist. Of course, you may have a ceiling effect here that's contributing, But the other bit is that nicotine seems to desensitize nicotinic acetylcholine receptors. So if you give them nicotine, it competes with the endogenous acetylcholine and may also desensitize them for a time. So again, you're limiting acetylcholine's effect. Very reasonable hypotheses. I will say that from my read of this as a non-pharmacologist, it's complicated. There's some parallel literature to show that nicotinic receptor expression actually increase with chronic agonist exposure. So this is a very fluid dynamic system, and I think we still have a lot of work to do to understand the relationship between us without even getting into differences between different nicotinic receptors, which is a whole nother question we could talk about. The thing that I wanted to highlight is this idea of negative salence, and this is always makes me, I don't often second guess myself, but it's made me wonder now, say maybe we picked one of the wrong targets in our proposal to NIH. So we really did have a measure of negativity bias in this study, looking at self-referential emotional processing. So this is, again, I have to give her credit, was Faith Gunning's recommendation. And this is called different things in literature, either the trait adjectives task or the emotional categorization task. But what it is you present to the participant a series of adjectives, either negative or positive. So and that person has to say either that adjective does or does not describe them. So maybe positive things like I'm happy, I'm generous, I'm kind. Maybe negative things like I'm selfish, I'm cruel, I'm uncaring. And people have to very quickly say, does that describe them or not? And it's something that we very, very clearly see that we do see as negatively biased in depression. It's related to depression severity, but also persists in remission. Some people propose it's an endophenotype, but interestingly enough, it is related to antidepressant response. And Catherine Harmer, who's in one of the European groups, has studied this pretty extensively, and that even the short-term change of this measure after even a week of antidepressant treatment may have a strong predictive value in predicting who ultimately will and will not respond to SSRIs. So really interesting. And what we found in this is over the course of treatment with nicotine is that even after adjusting for change in depression severity, we found people were more likely to endorse good words, good adjectives about themselves, and more likely to reject bad words. At the same time, the reaction time to endorse or reject these also speeds up. So we may also be modifying, the negativity bias here, which of course has a role with cognitive control network function. So finally, I do want to give this as a caveat. All this is only an open label trial. I didn't talk about cognitive performance, which drove this trial in the first place, because we really didn't find a clear signal. I think partly this was our error. We made the task a little bit too easy. But regardless, we're trying to replicate, trying to fix this in our subsequent study. And I think the take-home message is, do not give nicotine to your patients. Don't tell them to go smoke. We're way too premature for that. And my last thoughts is I really want to challenge all of us about how we think about aging. I see in my patients, and I see as I do this work, ageism is real, just like other isms are real with kind of misogyny, racism, everything else. I see in my older adults that they really struggle with this in many cases. And so I think really challenge yourself to think about how we think about aging in our older adults. There's a ton of really negative quotes you could offer about how people look at aging. Charles de Gaulle, of course, who is the former president of France, who led France against Germany in World War II, famously said old age is a shipwreck. And for many of our patients, that could be true, where they really have significant struggles and challenges as they get older. But I think our goal is to reframe this for our patient. And I really like David Bowie's comment, different type of leader perhaps, who really said that aging is the process to become who we're all really meant to be. And with that thought, I'm going to wrap up. I just want to thank a lot of collaborators over many, many years. And again, particularly highlight some of the collaborators I know nationally, both Brett Rutherford here as well as other people at other institutions. They have made the last year, the pandemic year, far more tolerable and honestly a lot more fun than it would have been. And with that, I'm happy to stop and we can move to questions. And thank you very much for your attention.
Wonderful. Thank you so much, Warren. That was really such an elegant presentation. You were able to cover so many domains so clearly, going from phenomenology to cognitive neuroscience to pharmacology, and presented in a way that we could all follow and understand. So thank you. So I will turn things over first to Dr. Rutherford to start our questions.
Well, thank you, Jonathan. Thank you, Warren, for really a tour de force through, as I expected from you, in a number of areas, and so much to talk about and discuss. Look forward to the discussion. I guess I could first start with just a commenty question of sorts for you, chimerical comment question. It was reassuring to me. I remember as I learned about vascular depression, and it's reassuring for me to hear from one of the heroes of the vascular depression story, that there's some divergent data out there and things aren't as clear cut. I remember when I did my first study and I said, wait a second, white matter burden and executive dysfunction are not predicting antidepressant response here. What have I done wrong? How have I messed up this study already? And that there are, so even though it's a canonical story, and it's a nice story in some ways of how an age-related facet can influence symptomatology and present in a certain way and be associated with antidepressant non-response and implicate a certain different therapeutic approach in a way. It's a complicated story, and as we normally, for example, and really this comes from what I've learned from Stephen Roos and Joel Sneed and other people here at Columbia. For example, we typically look at depression. Patients with depression, we look at their white matter burden, and it's much greater compared to similarly aged people without late onset depression. We say, aha. But if we just looked at it the other direction, everyone has white matter lesions. And if you just look at white matter lesions predicting depression in a more of a general sample, we don't see big effects generally. Also, that these nice discrete spots we see. I really admire the approach you took in the CAARe study, as when we look at these T2 flare scans and we see these nice discrete spots, sometimes we can forget that three-dimensional reconstructions of these blobs are unitary entities that kind of sheathe the lateral ventricles and are all over. And it probably, so to have a more fine-grained approach that doesn't just look at total white matter volume, hyperintensity volume, but looks at where these are, what specifically they're interrupting, into something going on back in the occipital lobe versus something that interrupts a key frontostriatal tract might be very different in their implications for depression and therapeutic response. So that approach seems very on point to me. And just in terms of a couple of questions, in the CAARe study data you presented, and as we looked at some of the contrast between depressed and non-depressed, what were the participants in that study enriched in a certain way for people who might have white matter stuff going on? Like, I can imagine just looking at all comers with depression that it might be tough to see between group differences. But if we said, oh, we're going to look at the people with executive dysfunction, or we're going to look at the people, as you've written about late onset, which can be a little trickier maybe, but something kind of more to enrich the sample and people we would expect to have more of a vascular presentation, might that be useful? And then I hope you'll say a few words maybe, which might be a more challenging question about, like, what the heck do we do with our late life depressed patients who have these white matter? I mean, that's the big problem. I've always found the least satisfying part of the vascular depression story is, okay, we know we want to prevent these things from happening, but what do I do with my patient who's got these lesions and is depressed and is not responding to antidepressants? What the heck do we do?
That is a great question. And, it's one thing I've always appreciated, that assuming the vascular depression hypothesis is generally correct, at least for some people, that only explains potentially some component of causality or how the disease may affect their presentation. It doesn't tell us what to do, And I think that people have proposed different things over the years, from exercise interventions to better management of the vascular risk factors. But my comment is, well, shouldn't we be doing that anyway? And does this really tell us anything that is actionable or anything that we can help improve the course of this? And the answer is, I haven't come up with anything really satisfying either. And so that's why in more recent years, I like to move things towards areas that are more modifiable and things that can be useful. I think that there is potentially some role, depending on how our data shake out, to say, can we use these data to stratify what to expect for participants coming in, knowing we can't have every subject or every patient comes to our clinic get an MRI to say whether they will respond in SSRI or not. But can we translate what we're seeing in the MRI into some clinical useful measure, whether it's trying a finer grain phenotypic description, looking at finer grain measures of cognitive performance, something that if you have a patient comes in and they do hopefully ideally a fairly straightforward test or a couple series of tests, you can say, this is someone who we know will do well with antidepressants. Here's your Lexapro, go have a good day. Or someone to say, they're not likely to respond and we really need to be more aggressive from the outset. And let's think about what that might look like. We're not there yet, but I think that's the real challenge in how to translate these things. I do think the vascular depression hypothesis has been useful, but it really, in helping understand brain biology to some extent, but it really hasn't made the clinical impact we would want it to have. In fact, I hope that answers that.
Yes, thank you.
Great. So I wanted to ask a question, Warren. So I try to think of late life depression as being fairly distinct from earlier life depression. A lesson that I've learned from Brett and others. And I guess what I was surprised by was looking at the functional MRI data that you presented. In some ways, it looks like the sort of the usual suspects and the usual networks. It doesn't look actually that different from other forms of depression. And I guess, is that a fair characterization? And if so, how do you think about that?
I always think about, I appreciate the questions. I always think about a comment I received a couple of years ago. I was presenting to Pittsburgh, where Marie-Louise Phillips kind of raised her hand and said, why do we think the networks related to depression would differ based on your age? And I think that's a fair comment. If we're looking at basic cognitive processes, affect regulation, response to emotionally salient stimuli, the networks are the networks. Now, the networks, of course, are going to change over time. What causes network dysfunction may differ dramatically in someone who's 20 years old versus someone who's 70 years old. But these, there's a lot of commonality here. This is why even in dementia, we can see a lot of effective symptoms develop in people that have no psychiatric history, where they develop difficulty with stress response, tearfulness, affect regulation, all this. So I think that the cause of the network dysfunction can widely differ. But again, at the end of the day, they're all the same networks.
Great. So there's a comment as well as a question. The comment is from Meg Haney, and I'll read that in a second. And then Brett, I'm going to ask you to cover Steve Roos's question, if that's all right, since that's a rather lengthy one.
Yeah.
So Meg Haney, who's an expert in substance use disorders, writes, wonderful talk outside my field, but very clearly presented. So thank you, Dr. Taylor.
Thank you.
All right, Brett, over to you.
Well, first, Stephen points out the precipitous decline in Duke basketball since your departure, and so that we're interested in that longitudinal study. And then gets us to nicotine, and there's been some interesting research on smoking here at Columbia. Denise Kandel, Stephen reminds us, has shown that smoking in younger people is associated with depression, but not necessarily drug abuse. So I don't know if there could be some kind of self-medication aspect there. And then Sandy Glassman, who's my grand mentor, of course, being Stephen's mentor, showed that depressed smokers who stopped smoking had a depression relapse curve similar to depressed patients who stopped antidepressants. And then, of course, we think about patients with serious mental illness, such as schizophrenia, who smoke at very high rates. And just that, so maybe we could have you talk more about this complicated story and even in what you presented. I was thinking too about these really, I was primed for a story maybe of how decline in acetylcholine signaling with age might lead us to get depressed later in life. But then in one of those last slides, thinking that it's actually excessive cholinergic signaling that might So is it more, and also the similarities with younger adults and what nicotine would really be doing in these people? So maybe you could say a bit more, like in terms of Stephen's question about what the smoking studies might suggest to us, and then you know, kind of trying to understand whether the nicotine story is similar or different in young and old, and how this kind of paradoxical effect.
Yeah, what Stephen says, as usual, he's spot on. And this is exactly what the kind of broader literature shows us, is exactly this, that, you know, when I was in training, I worked with Joe McAvoy. He did work in schizophrenia. He was really interested about how 90% of patients with schizophrenia smoke. And what does that mean for what are they trying to do, again, self-medicate? And we see something similar in the younger adults, not as higher rates, of course, but we do see that many of them do report that the cigarette smoking has antidepressant effects. The agonist and antagonist story has been one of the hardest things for me to get straight in my own mind. Again, maybe I'm not pharmacologist enough. And I think that probably the way I've kind of reconciled it in my own brain is, and again, I'll refer to our friends at Yale, if they are smarter about this than I am, is that you may be looking at a bell curve of cholinergic function, and depending on where you fit, you know, what your natural kind of cholinergic tone may vary. There's some thought in the nicotine literature, as I understand it, that more chronic administration may shift your cholinergic tone, that may have long-standing effects even once you stop smoking. So there is some thought that could you have chronic effects even once you know, that's over. But it's really, really challenging to say. I don't know if I have a good satisfying answer because I've really struggled with this. I think one thing that to me is very interesting as we think about the different administrations of nicotine, when people have pushed me on, is this a good idea or not? I always use 2 points I make to them. One is, of course, in psychiatry, we're getting more and more interested in how drugs that previously viewed as drugs exclusively of abuse may have therapeutic benefit, ketamine being the most notable. So they're, you know, at appropriate dosing with appropriate administrations may have utility. The second thing, though, is administering nicotine through a patch is very, very different than administering nicotine through a cigarette. And so you're not going to get the euphoric quick hit you would, you know, it's a slower absorption. You don't have that quick pathway through the lungs to the brain. You don't have necessarily the lung cancer risk because all the other things that are in cigarettes are not damaging your lungs because you're absorbing it through the skin. And it's just a slower overall process. And I think if you look at many of the other drugs we use in psychiatry that may have discontinuation syndrome or withdrawal risk, it's usually the ones that are shorter acting that have some higher risk there. I'm thinking of some of the benzodiazepines, where the longer ones, you know, may have a little bit less risk for withdrawal. So we may see a similar thing where people tolerate this better. I don't think I quite answered all of the question, but let me reflect to see if there's something I didn't touch on that would be helpful.
No, I mean, I think that was, I mean, more we could say about it, probably that was great. I don't know if, Jonathan, you want to move on with other questions or?
Sure, yeah, I think that covered it, thank you. So there's another question from William Tucker, who writes, I appreciate your concern about finding actionable interventions. In that light, does the often favorable response to ECT, including maintenance ECT in older depressed patients, offer any confirmation of your research on transmitters and cholinergic tone?
Good question. And I don't have a good answer for you because I honestly haven't, although being ECT trained, I haven't done it in a number of years, haven't really thought about it. ECT has been, in some cases, a really effective tool to help understand the neurobiology of late life depression. And in fact, the whole vascular depression story started from ECT studies, where it was the observation that there was a high rate of older adults referred for ECT who were otherwise treatment resistant. They noted, there was an awful lot of white matter disease in these brains. And that led us to where we are today. I think, I'm gonna have to punt on the question on what this comes to thinking about neurotransmitter systems, because I honestly have not considered that in the past.
Great. So I think that is it for the questions. I just wanted to say a couple things. One is to let people know that our Grand Round speaker next week will be Tom Lerner from the New York Genome Center. He'll be presenting on the genetic architecture of neuropsychiatric disorders. And then I wanted to thank Dr. Taylor again for presenting to us such a wide body of research and presented so clearly and elegantly. So thank you so much. And with that, we will adjourn.
Thank you all very much for having me.
Thank you, Warren.